Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the importance of improving blood pressure control. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Kim Bolden. Ms. Bolden, the floor is yours.
Thank you, Ryan. As Ryan mentioned, I'm Kim Bolden, Improvement Consultant with VHQC. Pictured with me is my colleague on the cardiac task, Terry Lindsay. On behalf of VHQC, I want to welcome you to the importance of improving blood pressure control. Before we get started today, I do have a few housekeeping items. First, today's session will be recorded. The recording will be emailed to you and will also be available on VHQC's website within 7 days. Also, we want to learn from each other, so today's session will be interactive. We ask you to please participate when questions are asked, either through the polling feature or the chat box. You may also use the chat function to send our presenter questions. He may not be able to address it during the session. However, any question we are unable to answer during the presentation, we will follow up with you after the webinar. And we are going to hold all Q&A until the end of the webinar, and we'll get to them after that. You may access the chat by clicking the chat icon on the upper right-hand corner of your screen. Finally, we would greatly appreciate your feedback to assist us with future planning. Please take a minute to answer the questions that will appear on the right-hand side of your screen after the presentation. And one last public service announcement for you. We want to ask you to please save the date of July 28th at noon for our webinar entitled Immunizations Are Not a Shot in the Dark. You'll see a link on the screen where you can register, and we'll also be sending out a link as well. The speaker, Dr. David Kim, Deputy Associate Director for Adult Immunizations with the Centers for Disease Control and Prevention, will share immunization recommendations for 2015. We will also discuss your challenges to documenting, tracking, and administering adult immunizations to the patients that you serve. So this is another event that you're not going to want to miss. And just for a moment, before we get started, I want to have Erica Morrison, who is our Learning and Action Network Manager, share a patient story with you.
Thank you, Kim. Before Dr. Raycox begins his presentation, I would like to ask you to think about your patients, particularly those with hypertension, as I share a brief story. 5 years ago, Gail made an important decision. She faced multiple risk factors for heart disease. She had a history, hypertension, diabetes, and obesity. She did not exercise and did not eat healthy meals. A typical breakfast included cookies, chips, and a cherry Coke. Gail's daughter was worried and asked her mother to make changes. With the support and encouragement of her family and doctors, she started to turn her life around. She started small, exercising just 5 minutes at first. Gail continued making those little changes to her diet and exercise regimen. Now she's 60 pounds lighter and has her health under control. As Dr. Raycox shares his strategies for hypertension control, consider how your practice might help patients just like Gail.
Okay, so without any further ado, I am pleased to introduce our speaker, Dr. Michael Raycox. Dr. Raycox has been a practicing family physician for 18 years. He was formerly a vice chair for quality at North Shore University Health System, where his efforts to use health information technology to identify patients at risk for undiagnosed hypertension led to North Shore receiving the 2013 Healthcare Informatics IT Innovator Award and published recently in Annals of Family Medicine. He more recently served as Director of Population Health and Virtual Medicine at Northwestern Memorial Physicians Group in Evanston and is an ONC Health IT Vanguard Fellow working with the Chicago Health IT Regional Extension Center to help kickstart their Million Hearts program for small independent practices in the metro Chicago area. In 2014, Dr. Raycox's office was recognized as one of the 30 sites in the United States to win the designation of Million Hearts Hypertension Control Champion. At the American Medical Association, Dr. Raycox serves as the Director for Chronic Disease Prevention Strategies for Improving Health Outcomes, focusing his efforts on helping to improve blood pressure control nationally. Welcome, Dr. Raycox. Thanks so much for joining us today. I'll go ahead and turn it over to you.
Thank you, Kim, and it's a pleasure to be talking to you today. I really appreciate the opportunity. We'll get started right away, and I want to dive right in with the objectives. And at the end of the webinar today, I'm hoping that you'll all have a better understanding of the importance of controlling elevated blood pressures and why measuring blood pressures accurately are so vital, and how reducing clinical inertia to improve blood pressure control is critical, and how you can do a better job in your practices and health centers doing that, and how to increase patient engagement to increase self-management for patients, and what one example looks like for putting all of this together in everyday practice. So I usually start talking with this slide just to illustrate that this is the top 10 causes of death in the United States in 2012. In 2013, it looks very similar. The same top 10 causes are here with number 4 and number 5 swapping places. But the main takeaway message from this slide that I want to try to illustrate is that hypertension occupies as a factor for 4 of the top 10 causes of death as a contributing factor. And many of these deaths are preventable. And so that's really the main takeaway. And as I'm sure you've heard many times, hypertension is the leading cause of death and disability in almost every country in the world. So this is an illustration of one of the largest meta-analysis ever done in hypertension, and a graphic illustration of over 1 million patients that taught us in 2002 as a primary care physician. It was put in JNC7, and what it really illustrated very clearly was that there is a doubling of risk in every decade of life from 40 to 89 for every rise in blood pressure above 115/75 of 20 millimeters systolic and 10 millimeters of mercury diastolic over 115/75. We see a doubling of risk of heart attacks and stroke death. And so it was very clear looking at this huge meta-analysis that as a person's blood pressure rises, risk of death from cardiovascular disease rises as well. So why is elevated blood pressure so deadly? Well, elevated blood pressure causes damage to blood vessels, which leads to remodeling and eventually organ damage. And what most people need to remember, they don't always understand, is that high blood pressure is a vascular disease affecting the vasculature throughout the body, and that's why it has such devastating consequences. But what we learned back in the 60s from the VA 1 and 2 trials was that lowering blood pressure with medication actually lowers the risk of heart attack, stroke, and death. So, stating the obvious here, treating high blood pressure lowers risk, and that is why it is so important that when we see a patient with high blood pressure in the office, we act. This is a snapshot of the current trends in the United States for hypertension, and this is a really important slide. Demonstrating that 1 in 3 U.S. adults now have hypertension, which is about 80 million people. But unfortunately, only about half of those people are treated to goal, in spite of the fact that most do have health insurance and most do see a physician or a clinician several times a year. And while we've seen a trend in annual deaths due to heart attacks dropping significantly over this time in the last 15 years, deaths due to hypertension have skyrocketed since 2000, up nearly 62%. And with the prevalence of hypertension expected to rise from 33% to 41% by 2030, there's never been a more important time for us to improve blood pressure control. So why is it that we're doing such a poor job at controlling blood pressure with just over a 50% control rate? And what can we do to improve control of blood pressure in our practices and health centers? Well, in order to succeed, we need to realize that there are multiple factors that contribute to uncontrolled blood pressures. There's patient factors, there's physician factors, and there's system factors. And we need to address all of them if we're going to have a chance to significantly improve blood pressure control, both locally in our practices and across the country. So we'll start with clinician factors, but this is a very interesting fact, is that when clinicians are asked why they didn't act when they had a patient in front of them in an exam room, the number one answer that they give is that they didn't believe that the blood pressure represented the patient's true blood pressure. They didn't believe that the measurement was accurate, was an accurate representation of the patient's blood pressure. And we know that everybody's blood pressure is variable. Within patient variability is significant. Blood pressure fluctuates constantly. But poor measurement technique makes blood pressures less reliable, which can lead to clinical indecision that can adversely affect patients. So what this might look like in practice is that if poor technique leads to falsely low blood pressures, we may not diagnose patients that have hypertension, potentially leading to heart attacks and strokes that could have been prevented with treatment. And if we measure patients falsely high, which is much more common due to common measurement errors and white coat effect and anxiety and poor measurement technique, we're putting patients at risk for being overtreated and overdiagnosed with hypertension. And the result of this is harming patients from overtreatment that can result in syncopal episodes, loss of consciousness, falling, and, hypotension, potentially damaging their kidneys. So we can actually do significant harm by overtreating patients that don't actually have hypertension. So this is the bottom line. We need accurate, reliable blood pressures to make sound medical decisions. And this is why accurate blood pressure measurement is so vital. So what we're going to do now is go through the four most common ways to measure blood pressure. 24-hour ambulatory blood pressure monitoring, or ambulance ABPM is the way we abbreviate that. Self-measured blood pressure, or SMBT, otherwise known as home blood pressure monitoring. These two are the most accurate ways to measure blood pressure. They're both done out of office. And then in-office measurement, including automated office blood pressure, or AOBP, which you may not be familiar with, and office standard routine office blood pressure measurement, which I'm sure you're very familiar with. We'll talk about the pros and cons for these four methods. So 24-hour ambulatory blood pressure monitoring has, it's the gold standard for accuracy. It is the most predictive of outcomes for predicting future events. You can rule out white coat hypertension, which is where a patient may have an elevated blood pressure in the office consistent with hypertension, but out of the office they have normal blood pressure. And it can identify patients with masked hypertension, where they have a normal blood pressure in the office, but they actually are truly hypertensive when they're not in the office. And this is a very difficult problem to identify and almost impossible to diagnose unless you're using an out-of-office blood pressure measurement technique. And the other thing that's unique to 24-hour ambulatory blood pressure monitoring is that it gives blood pressure measurements when the patient is sleeping. And the reason that this is important is not only can it give clues to conditions like sleep apnea by having an elevated blood pressure during sleep, but elevated blood pressure during sleep is actually the most predictive of risk of morbidity and mortality for patients with hypertension. The cons to 24-hour ambulatory blood pressure monitoring are that it's expensive, that it's not always covered by insurance, and that it's not always available and often takes a long time to schedule an appointment. Next, we'll talk about self-measured blood pressure or home blood pressure monitoring. This is another excellent technique that predicts future events much better than office blood pressures. You can rule out white coat hypertension and masked hypertension that we just talked about. It's relatively inexpensive compared to 24-hour testing, and it is very convenient compared to 24-hour testing. But some of the cons are that a patient has to have a home blood pressure monitor, and that it doesn't give blood pressure when you're asleep. And unfortunately, you can't just wake up and use your home blood pressure machine and consider that an asleep blood pressure, even if it's done in the middle of the night right after you wake up. So those are some of the cons. The other is that you actually need quite a bit of training for this to be useful. A patient needs to be trained extensively for self-measured blood pressure to be done accurately, and then there has to be good communication back to the clinician's office and care team for this to be an effective method to reduce blood pressure control, or increase blood pressure control, excuse me. And the next method is automated office blood pressure measurement. This is a technique where you use fully automated blood pressure monitors. These are monitors that can be used with no clinical staff in the room. That's why they're considered fully automated. They can take up to 6 measurements at intervals between 1 and 5 minutes. The machine then averages the blood pressure, giving you a single mean blood pressure, which correlates extremely well to the daytime average on a 24-hour test, which is very predictive of predicting cardiovascular events. It also can help completely eliminate the white coat effect in most patients because there are no clinical staff in the room. So it's a very, very accurate means of testing blood pressure in the office. It's the most accurate, actually, of the in-office measurement techniques. The cons are that the machines are quite expensive. They vary between $600 and $1,000 a piece, and they do take a little more time to use. I will mention that the country of Canada uses these machines as part of their guideline. This is where the machines were invented in Canada. They are part of their everyday workflow. There's one out of every 3 primary care doctors they have a machine for 1 out of every 3 primary care doctors, and I will note that Canada is the most controlled blood pressure country in the world. The machines they're now starting to spread in the United States, and Mayo Clinic and Cleveland Clinic have now switched over to using these machines as well. They're extremely effective. And finally, we'll turn to what most of us use every day, which is routine office blood pressure measurement. And the main reason being that it's convenient, which is why we use it, and it does have the potential to predict future events if everything is done correctly. Meaning, positioning is done properly, and meticulous detail is spent to properly size the cuff, and a lot of things have to go right for an office blood pressure to be accurate and be predictive. And this is an inexpensive technique, but there are a lot of barriers to doing this correctly. It requires a lot of rest time. It requires a lot of training for the person performing the blood pressure measurement, which is called the observer. And there can be a lot of bias from the person taking the blood pressure measurement. Everything from, the most common is terminal digit preference, where we see in some studies up to 80% of the blood pressures ending in the number 0, which is a major problem for rounding the number up or down. And another con is that you can't rule out white coat or mass hypertension using this technique, and it doesn't give any information about asleep blood pressure. And according to major studies, this technique is rarely done correctly. We just did a recent study showing that about 99% of the time when we looked at people who were recently trained to use blood pressure measurement techniques using machines, even in an office-type setting, the measurement was done incorrectly, and that is not unheard of. So let's talk about, we're going to do a polling question about how many measurement errors you see in this picture. And you see A, B, C, and D on your screens. And let's take a poll about how many measurement errors that you see on this screen. We'll give you another 15 seconds to answer. Okay, we're at time. Jennifer with WebEx, do we have the polling answer?
We'll have them in about 10 seconds.
Okay, thank you. Okay, it looks like the highest number looks like the answer was D, and that is correct. But the correct number of errors here is actually 7. And so this is what it takes to do a proper blood pressure. That you have to have proper back support. The arm has to be supported at heart level with the cuff at heart level. You have to have the cuff placed at mid-arm level over a bare arm. She's got it here over a sweatshirt. Her legs are crossed. Legs need to be uncrossed. Feet need to be firmly planted on the ground or a stool. There should be no talking, no listening, no texting, no cell phone use of any kind. And the cuff needs to be sized properly. And actually, in this case, the cuff is not sized properly, but you wouldn't know that unless you were familiar with this equipment. So This is very common to see these kinds of errors, and they can cause significant measurement errors having any one of these, let alone having 7 or more. So these are the common factors contributing to blood pressure measurement errors. There are observer factors, and again, the observer is the person who is doing the measurement. So using the wrong cuff size is thought to be the #1 error. More recently, we're seeing people having less or no rest as a common error. Again, placing the cuff over clothing, extremely common. Improper positioning, as we just reviewed. The terminal digit preference is a problem. All the things we just talked about. And if you're doing manual and not using a machine, doing manual auscultation, inflating the cuff and then deflating too rapidly is a major problem. Patient factors, if a patient has a full bladder, you can have at least a 10 millimeter error there. Patients on stimulants of any kind, recently smoking a cigarette, caffeine. We've all heard patients say that they just had a cup of coffee or smoked a cigarette before high blood pressure. Recent exercise can lower blood pressure, or recent meal can lower blood pressure. And then there's system factors like having blood pressure cuffs mounted over exam tables so that the only place you can take a blood pressure in an exam room is if the patient's sitting on the exam table, and that's a very common problem. So it's sometimes you're a victim of the system that you work in, but these are all very common contributing factors to errors in blood pressure measurement. So these are a few examples of how significant these measurement errors could be and how much they can actually impact your clinical decision making. And if you have a 2 to 3 millimeter error in blood pressure measurement, it can be significant sometimes, especially for patients who are on the border of being diagnosed or controlled. So you can imagine, although these are cumulative, with a few of these errors could be, you can see how you can easily have a 10 to 20 millimeter error in blood pressure by having several of these errors. And obviously, again, major contributing factors to clinical indecision. And this is one of the reasons why, if you're going to use manual office blood pressure or any of the techniques that we've talked about today, you're going to have really good technique. So this is what correct positioning should look like. We recommend using an automated, validated blood pressure device because it reduces human error and human bias. Sitting in a chair with arm support or with your arm on a table is a great idea. Again, cuff over a bare arm, and the cuff needs to be correctly sized using the markers on the cuff. And remember, it's the bladder size that needs to be at least 80% of the circumference of the arm and 40% of the width of the circumference of the arm, not the actual nylon cuff itself. A lot of people don't realize that. And again, no talking during the measurement. And what we like to recommend to have a really accurate measurement is that the first blood pressure that you take is elevated, greater than 140/90. That's when you absolutely need to rest the patient for 5 minutes, make sure that the patient has an empty bladder. And at that point, we recommend taking multiple measurements, at least 3 measurements, and averaging them. We call that a confirmatory measurement for people who screen high, and that way you'll get a much more predictive blood pressure measurement, much more accurate. You'll have a much better idea and that you can trust the blood pressure measurement, that it correlates better with outcomes. So given all that, why do we continue to use office blood pressure measurement? Well, there are a lot of guidelines that say if you're going to diagnose somebody with hypertension, England in 2011 was the first country to say you can't do that anymore. You're going to have to use a 24-hour ambulatory blood pressure monitor or an out-of-office measurement like home blood pressure monitoring. Canada followed, and now there's a draft recommendation from the U.S. Task Force in the United States saying that we may be next, requiring 24-hour blood pressure monitoring to make the diagnosis of hypertension in a patient with elevated office blood pressures. But the reason that we continue to have office blood pressures be acceptable in this country is that we have the opportunity to obtain them, that we have newer technology with these machines so that we have a better chance of obtaining a better measurement with less human error and less bias. And with protocols that are standardized, we can reduce variability and errors and increase workflow efficiency to obtain a better measurement. And this concept of obtaining multiple confirmatory measurements and averaging them really does increase diagnostic accuracy and reduce misclassification. So it is possible to use office blood pressure measurements, but you really need a protocol to do that effectively. So realize that just by measuring blood pressure accurately, you're not going to start seeing dramatic improvements alone in blood pressure control. And so we have to address clinical inertia, and this is felt to be one of the most significant factors for why blood pressure is uncontrolled in this country. And there are two main factors on the clinician side for why clinical inertia is such a major problem. And the first one is that when you have a patient in front of you with an elevated blood pressure, clinicians fail to initiate or escalate therapy when the patient's got a blood pressure greater than 140/90. And the second is that they fail to have frequent follow-up. We recommend every 2 to 4 weeks if a patient's blood pressure is uncontrolled until the blood pressure becomes controlled. The second factor is on the patient side, non-adherence to a treatment plan, whether it's lifestyle change or more commonly it's due to a lack of adherence to following treatment with medications. So these are the most common causes for what we call clinical inertia. Clinical inertia can be broken down into diagnostic inertia when a clinician fails to make the diagnosis of hypertension, or therapeutic inertia when a clinician fails to escalate therapy. But together, it's simple to just call them clinical inertia. I find it much easier to just keep it as one word. So what are the factors that contribute to clinical inertia? Well, as a clinician, we talked about the most important being failure to initiate or escalate therapy to get a patient to goal, and failure to recommend follow-up. These are absolutely the most common. But, failure to set clear goals, also an extremely common problem. Underestimating the needs of a patient. There are competing factors. Patients come in, as we all know, with multiple medical problems, or just one medical problem that's not high blood pressure. If they come in with knee pain or a sinus infection, you may not notice the high blood pressure. They may not want to deal with the high blood pressure, but it can be very difficult. And then there's patient factors. And blood pressure has very few or no symptoms in most cases, and that's one of the biggest factors. Poor communication is extremely common. How many times have you heard a patient come into the office off their medications and they say, well, I didn't think I was supposed to take my medicine today because I thought I was going to have my blood drawn, or I filled the 30 pills that you told me to take and I ran out 3 months ago and you just told me to take the 1 month supply and I thought that's all I was going to need. That's on us for not communicating clearly. But again, going back to the main causes, it really comes down to medication non-adherence, and that can come down to communication issue, but it can also come down to a patient having too many medications, side effects, or cost of medication, all very common. And then there's system factors leading to clinical inertia, such as poor communication between staff, not having a registry. Sometimes the system works against you and it can contribute to the problem. So let's go into the next polling question it's a question about treatment protocols. And I'm curious, how many of you, do you use treatment protocols or not? It's a yes or no question. And we'll have that up for you shortly. And Jennifer from WebEx, do you have that poll up? Thank you. So we'll just be a few seconds here and we'll have the results. Okay, it looks like nobody is using a treatment protocol for treating high blood pressure. And this is not surprising. National experts do recommend that we use treatment protocols, but they have not been widely adopted. The reason that most national experts recommend using them is that, primary care providers are well-trained, but, we could use a little bit of help because protocols tell us exactly when patients need treatment, what treatment that they should get, and how soon follow-up should occur. And it's just like a little bit of help telling us what the evidence shows, when and how to use it. It just makes your life a little bit easier. And many protocols, such as the Million Hearts protocol that's available on their website, can be customized for your practice or health center so that you can use it and customize it for your individual practice. And one of the things that I always say is even if you use a treatment protocol, it should never trump clinical judgment. So you should always use your clinical judgment even if you have a protocol. But protocols can really help make your life easier and prevent delays in treatment intensification. We know that by delaying treatment as little as 6 weeks or follow-up by more than 10 weeks actually increases the risk of heart attack, stroke, and death in patients with high blood pressure. So having a protocol to help encourage not making those mistakes and delays can really, really help improve blood pressure control and actually decrease morbidity and in some cases mortality. So we highly recommend using a standardized treatment protocol. Same is true for using single pill combination therapy, made famous really recently by Kaiser, using lisinopril HCTZ. Kaiser went from using about 10 prescriptions a month to over 13,000 prescriptions a month in a period of about 8 years as they doubled their control rate from over 40 to 80% control in over 1 million patients. Single pill combination therapy can be escalated more quickly using fewer pills to get patients' blood pressure under control more quickly. And it also addresses adherence issues. And, by having less pills for patients to take and being able to have less fills for patients, it makes it easy for them to stay on track and actually increases adherence sometimes as much as 26%. So single pill combination therapy is another very effective tool in improving blood pressure control. It's another part of our recommended strategy. And so now sort of changing gears and moving towards increasing patient engagement. One of the tools that we use successfully is using evidence-based communication strategies. And really, without getting too fancy, this is if you could read an article or take a crash course in motivational interviewing, that's really what this is. And we do a lot of talking at patients instead of communicating with patients and listening with patients. So if we did a little bit less talking to patients and a little bit more listening to patients, I think we'd be more successful in coming up with shared management plans that take what the patient wants into a little bit more of consideration. And where that's important is, sure, we've got our great compliant patients who are going to do whatever we want, but there are so many patients. Sometimes at the end of the year, sometimes up to 50% of patients on medications aren't taking them, and we've got to do a better job at improving medication adherence. And so these are just some basic strategies that the evidence shows can really make a difference in improving blood pressure control and improving patient adherence. So open-ended questions, reflective listening, positive reinforcement, these common techniques that, are essentially components of motivational interviewing. So open-ended questions, instead of asking yes-no questions like, are you taking your medicine every day, asking things like, what are you doing to manage your blood pressure, giving them a chance to talk. Reflective listening, where you actually listen to a patient and then try to find some insight in what they're telling you. I'll give an example in a few minutes. Always try to be positive and supportive. Absolutely critical in working your relationship with your patient to be successful in sustaining behavior change. And one of the most successful techniques for making sure a patient understands what you've learned today in that encounter, to make sure that they understand what the new plan is a technique called teach back, where instead of just handing them an after visit summary, you ask them verbally, so what is the plan today, or what did you learn today, and have them actually speak it back to you so that you can make sure right then and there they understand what's going on. So, quick example, you might, instead of asking a patient, are you having trouble taking your blood pressure medicines, or are you taking your medicines, you could ask, how are your blood pressure medicines working out for you? Very simple questions like that can really make a big difference to try to get patients to open up, communicate a little more honestly. We've all sort of seen a person like this where, somebody, I've certainly had dozens and dozens of patients where I've practiced who've said, I hear you, but I'm not going to take the pills that you want me to take because I don't think they're natural. And, you hear those kind of statements and, you can't win all of these things, but what we like to say is try to work the relationship, try to work your communication strategies. And when you hear something like that, instead of just throwing at them, most medicines are natural and, most pharmaceutical products are derived from plants, which maybe they'll listen to and maybe they won't, by asking them why, tell me why you think, medicines aren't natural, and by asking things like, it sounds like you want to control your blood pressure, but you don't feel comfortable taking medications. What do you see as a solution? Turning it on them to offer up a solution is a really great way to find out what they're willing to do or not do. And, what we don't want to do is just abandon the patient and let them have their heart attack or stroke and to spite them by just saying, well, they won't take their medicine and too bad for them. You have to see them back frequently. Don't forget that. It's critical that you really try to see patients back as much as you can, even if they're not listening to you, so that you can eventually, hopefully, break through, try to get them to adhere. And finally, back to self-measured blood pressure a little bit. One of the best uses of self-measured blood pressure, we talked about how accurate it is, and it's better for predicting outcomes. It reduces variability, it helps improve blood pressure control. But one of the best things about it is it actually engages patients in self-managing their disease. It increases adherence to medication in many patients, and it actually improves their adherence to lifestyle change, which is a really nice thing. I've got one last polling question for you, Jennifer, if you're ready. If you all know what a normal home blood pressure is, what is the threshold for diagnosing a patient with hypertension using home blood pressure monitoring? And I'll give you some time to think about that. One of the important things to realize is, again, without the white coat effect, without being in a clinician's office, out-of-office measurements are lower than measurements taken in the office. And so if you have to be aware of that, it's not 140/90 to diagnose a patient. At home, it's actually, these are supposed to be greater than or equal to, by the way, and a blood pressure of greater than or equal to 135/85 in the home setting, which it looks like most of you do, is consistent with the diagnosis of hypertension and requires action, whereas in the office it would be 140/90 for most patients. So that's, it's good that 50% of you knew that, and it's very important. So again, going down the same theme of patient engagement, lifestyle change for improving blood pressure control, educating our patients to do these things like diet and exercise, and low salt intake and alcohol in moderation, no smoking. These can add up to, diet alone, changing from an American diet to a DASH diet, the dietary approaches to stop hypertension, or a Mediterranean-style diet can be equal to taking a pill. And unlike, some of these are actually cumulative. And so, people hate taking pills. If you can, the hard part about this is sustainability. So this is not easy, but a lot of people don't want to take pills, and if they can really engage in lifestyle change, it can either delay the onset of having to take a pill or reduce the number of pills in some patients, but realize most patients with high blood pressure will actually end up on medication or require medication, but this can improve their risk profile, especially if they're sedentary, getting them moving, but often it can delay needing more medication or reduce medications if you can get them to follow along. Just how much? This is from the American College of Cardiology, American Heart Association, evidence-based paper that came out on lifestyle change, I believe in 2013, and just showing the drops that you can see with weight loss, with sodium reduction, of even just, even if you don't get your sodium down to the recommended 2,300 milligrams a day or even 1,500 milligrams a day, no matter where you're at, just by reducing by 1,150 milligrams of sodium a day, you'll see a fairly significant drop in blood pressure. And weight loss of 10 kilograms instead of 11 pounds, you'll see an even more significant drop in blood pressure as well. So these are very effective approaches. The hard part really is sustainability. And so, I've thrown this together. This is one of the methods that I use to become a hypertension control champion for Million Hearts. This is what we work on. And the AMA and Johns Hopkins have created a framework for controlling blood pressure and checklists based on that framework. And we call these the MAP checklist for improving blood pressure control. MAP stands for Measure Accurately, Act Rapidly, and Partner with Patients, Families, and Communities. And these checklists are updated annually and incorporate decades of evidence, much of which we've reviewed today, along with evidence-based tips for staff and patients to work together to manage uncontrolled blood pressure. The Measure Accurately checklist helps teams to get actionable blood pressure data, and the Act Rapidly checklist helps clinicians reduce clinical inertia, and the Partner with Patients and Families and Communities checklist helps engage patients in self-managing their hypertension to reduce non-adherence. And they're very simple to use. They work extremely well, and they're practical. And they're available. The AMA has created a website for practice transformation and reducing physician burnout called Steps Forward. The website is stepsforward.org. And we've created a improving blood pressure control module where you can get 1 hour of CME and download our checklist and several tools for improving blood pressure control and get an hour of CME. And like all of the modules on the Steps Forward website, the CME and the downloads are free. So it's definitely worth checking out, and it can really help your practice or health center get some really helpful tips for improving blood pressure control. And a lot of the tools, posters, just some very simple things in the checklist are available there for download for free as well. And again, you don't need to be an AMA member, and it's all free. And so I'm going to stop there and open it up for questions. I think we're okay on time here. If anybody has any questions they want to chat in about anything we've talked about today, you can go ahead and do so.
The floor is now open for questions. If you do have a question, please press the number 7 or the letter Q on your telephone keypad. Questions will be taken in the order they were received. If at any point your question has been answered, you may press 7 or Q again to disable your request. Please hold while we wait for the first question.
Hi, Dr. Raycott. I just had a question. Have you had experience using patient portals and how they play a part in patients using the portal to report their blood pressure measurements and that type of thing? Does that seem to be a useful and beneficial tool?
Yeah, absolutely. I mean, we recommend, we have a whole, one of the things that's available on that Steps Forward module is a large self-measured blood pressure program that contains, how to effectively use home blood pressure monitoring in your practice. And, portals are great for exchanging blood pressure information. One of the keys, though, are that when patients go out and buy a blood pressure monitor, you need to make sure that they know how to use it, that they've been trained to use it properly, that it fits them, that it actually measures accurately for them. And once that happens, then transferring the data is great because they don't need to come in as often. You can actually titrate. Studies show that titrating medications from home, once you're sure that the technique is good, that the measurement is reliable, can really be extremely efficient. And it's a great way to communicate information. It's secure and reliable. And we actually have protocols that we recommend for measuring at home accurately so that those home blood pressures, if done properly, 2 blood pressures in the morning and 2 blood pressures in the evening for a week, can actually predict future outcomes as well as parts of 24-hour testing. So it can be very effective, and the portal is a great way to communicate that information. It looks like there's a question in the chat asking, would an inaccurate blood pressure measurement lead to over-reporting of hypertension? It seems like if taking during blood pressure measurement raises it, how come there isn't an over-reporting problem when it sounds like what you've talked about is an underdiagnosis problem? Actually, you're absolutely correct. What I'm talking about is increasing diagnostic accuracy. So there is an over-reporting problem. I'm not talking about an under-reporting problem. I'm talking about an inaccurate reporting problem. So what I want to see, and you heard me say about how what it looks like in practice is that if you're diagnosing patients and over-treating them, that you can cause harm. We mentioned that. And if you're not diagnosing them, you can withhold treatment and cause harm. So it works both ways. So one of the things that they found out in England when they started to use 24-hour blood pressure monitoring and home blood pressure monitoring was that 40% of the patients that they thought had hypertension based on office blood pressures didn't have blood pressure problems, did not have hypertension. And 33% or so in Australia, same thing. And in Australia, it was 33% who were on medication diagnosed with hypertension when they did home blood pressure monitoring over a period of time. They actually took people off of their medication and tested them over, a prolonged period of time with home blood pressure monitoring. And it turns out a third of the people that had been diagnosed with hypertension didn't actually have it. So we have a dual problem in that we're over-treating people that don't have hypertension and we're under-treating people who do. But you can't just assume that the reason that I know we have a problem is that deaths due to hypertension are up 62% since 2000. So there's no question that we've still got a major hypertension problem. We're seeing a lot of strokes. We're not seeing a reduction in stroke deaths necessarily as much as we'd like to see. We're seeing a lot of kidney failure. We're still seeing a lot of heart disease. Even if we're seeing less death from heart attacks, we're still seeing heart attacks. So it's a good question, but what we need is more diagnostic accuracy. But then once we make the diagnosis, we're still doing a very poor job of controlling blood pressure. So I hope that answers your question from the chat.
Once again, if you do have a question, please press 7 on your telephone keypad. Once again, that's 7 on your telephone keypad.
And when Kim takes back over, just so you know, I'll continue to monitor the chat for the remainder of the conference in case any more chat questions come in.
Okay, thanks again, Mike. That was really insightful. I thought that was a lot of valuable information, and I really appreciate your taking the time to speak with us today. Jennifer, if I could get you to please post the evaluation questions. And again, I ask that everyone take a few moments to complete the evaluation. And thank you for your attendance today. don't forget, mark your calendar. July 28th, immunizations are not a shot in the dark. Thanks, everyone.